In this video, we will be discussing the thyroid gland. We will be discussing the pathophysiology, clinical manifestations, pharmacological and surgical management of hyper and hypothyroidism. Before we get started with the two extremes of thyroid function, let us first review the thyroid and what normal thyroid functions look like.
In this video, we'll be using Skittles to represent different hormones. Thyroid-releasing hormones will be the red Skittles. Thyroid-stimulating hormone will be the orange Skittles. And then lastly, our thyroid hormones will be represented in two colors. T3 will be the yellow Skittles, and T4 will be the green Skittles.
The thyroid gland is divided into two lobes and lie on either side of the trachea, and its function is to regulate the metabolic rate of the body. The gland normally is not visible on inspection but may be palpated. The thyroid contains two types of cells, the perifollicular cell that secrete calcitonin and somatostatin, and the follicular cells, which create and release thyroid hormones. Thyroid hormone is regulated through a negative feedback loop that involves the hypothalamus, the anterior pituitary, and the thyroid gland. When the body is low on thyroid hormone, the hypothalamus is stimulated to release thyrotropin-releasing hormone, or TRH, into the hypothalamic pituitary portal system. The TRH then stimulates the anterior pituitary to release thyroid-stimulating hormone, or TSH, into the bloodstream and binds with receptors on the plasma membrane of the thyroid follicular cells, which then releases the stores of thyroid hormone and stimulates the creation of thyroid hormone. As the levels of thyroid hormone rise in the body, the hypothalamus stops the release of TRH. As mentioned earlier, the thyroid hormone is created in the thyroid gland. Iodine is essential for thyroid hormone and is transformed in the thyroid gland from iodide. The iodine combines with tyrosine in the thyroglobin to form iodotyrosine, and then the iodotyrosine is converted into thyroid hormone by thyroperoxidase. There are two types of thyroid hormone that is created. T3, which is the coupling of monoiodotyrosines, which is one iodine atom and tyrosine, and also they make diiodotyrosine, which is two iodine atoms and tyrosine. It also makes T4, which is the coupling of two diodotyrosines. 90% of the thyroid hormone produced is T4. However, most of the T4 is converted into T3 to act on target cells. Thyroid hormone has many effects on body tissues and has significant effects on the growth and maturation of tissues. Thyroid hormone has effects on cell metabolism by altering protein, fat, and glucose metabolism, and as a result, heat production and oxygen consumption are increased.
Hyperthyroidism is a condition where the body has increased levels of thyroid hormone. Primary hyperthyroidism results from increased levels of thyroid hormone that can be caused by Graves' disease, hyperplasia of the gland and increased thyroid hormone production, toxic multinodular goiter, and solitary toxic tumor and pituitary tumor. Clinical manifestations of hyperthyroidism include thin hair, weight loss, tachycardia, which can cause heart failure, warm skin, sweaty palms, diarrhea, irritability, sleep disturbances, exophthalmos, and peritibial myxedema. Graves' disease is the cause for majority of the cases of hyperthyroidism. In Graves' disease, the body creates thyroid-stimulating immunoglobulins, TSI, that bind to the TSH receptors on the thyroid. Once bound to the receptors, TSI stimulate an increased release of T3, the active form of TH. This will also lead to the formation of a goiter. TSIs are not affected by the negative feedback loop and will continue to stimulate the production of thyroid hormone. Patients with Graves' disease may have clinical manifestations such as visual changes and exophthalmos caused by fat building up behind the eyes, causing them to protrude, and peritibial myxedema, also known as Graves' dermopathy. This is characterized by swelling and redness on the anterior portions of the tibia. Thyrotoxic crisis, also known as thyroid storm, is severe hyperthyroidism. It can be triggered by physical or mental stress. The patient will present with tachycardia, hyperthermia, nausea, vomiting, diarrhea, and they may be agitated or delirious. Treatments include steroids to decrease the inflammatory response, medications like
propylthiouracil
to inhibit thyroid hormone production, radioactive iodine therapy, which destroys thyroid cells, and surgery, or the removal of the thyroid gland. Patients will also need a beta blocker to protect their heart.
propylthiouracil
Impedes thyroid hormone formation by inhibiting the incorporation of iodide molecules into amino acid tyrosine. This impedes the formation of thyroid hormone. Propylthiouracil has the added ability to inhibit the conversion of T4 into active T3 in peripheral circulation, but it cannot eliminate thyroid hormone that is already in the bloodstream, so it will take 2 weeks for the medication to take effect. Propylthiouracil has black box warnings because it can lead to bone marrow and liver toxicity. It also has side effects of leukopenia, loss of stamina, and weight gain. Surgery is another option to treat hyperthyroidism. The patient may opt for partial or total thyroidectomy. With a partial thyroidectomy, part of the thyroid is still functional and can release thyroid hormone. If this part of the thyroid still releases too much thyroid hormone, the only other option is a total thyroidectomy, which then sends them into hypothyroidism.
Hypothyroidism occurs when there is insufficient production of thyroid hormone by the thyroid gland. Hypothyroidism is the most common disorder of the thyroid and it can be classified as primary. It occurs when there is a loss of thyroid function leading to a decrease in production of thyroid hormone, an increase in production of both thyroid-stimulating hormone and thyrotropin-releasing hormone. Hypothyroidism can be caused by iatrogenic loss of thyroid tissue due to surgery, radioactive treatment, iodine deficiency, or an autoimmune thyroiditis, also known as Hashimoto disease, which is a gradual inflammatory destruction of thyroid tissue due to an infiltration of lymphocytes. Hypothyroidism can manifest itself over months or years. The decrease in thyroid hormone is followed by a decrease in energy metabolism and heat production. The individual will develop a low basal metabolic rate, cold intolerance, lethargy, and a slightly lowered basal body temperature. A decrease in thyroid hormone can lead to excessive TSH production, which stimulates thyroid tissue and can cause the development of a goiter. A sign of long-standing hypothyroidism is myxedema, characterized by swelling of the skin and underlying tissue due to the binding of water within the proteins and mucopolysaccharides that separate the connective tissue fibers. The non-pitting boggy edema is seen around the eyes, hands, feet, and supraclavicular fossa. Slurred speech and hoarseness can also occur due to a thickening of the laryngeal and pharyngeal mucous membranes. At this stage, myxedema coma can occur and is considered a medical emergency. Signs and symptoms of myxedema coma includes hypertension, hypoglycemia, hyperventilation, hypothermia, without shivering, and a buildup of lactic acid. Hormone replacement therapy with levothyroxine is a common treatment for hypothyroidism to restore normal TH levels. Levothyroxine, or Synthroid, is a synthetic thyroid hormone that works like endogenous TH, increasing metabolism, which in turn increases cardiac output, the flow to the kidneys, and overall oxygen consumption, as well as self-reproduction. Treatment depends on the person's age, duration, severity, and comorbidities, particularly cardiovascular disorders. It's important to remember that symptoms of hypothyroidism in older adults should not be attributed to normal aging. The geriatric population is more sensitive to an increase in thyroid hormone, and a low dose is better to start off with to prevent a decrease in hepatic and renal functioning.
Now let's compare the two. Hypofunction versus hyperfunction. So we start with hypofunction, where there is loss of hair in comparison to the thinning of hair in hyperfunction. Now we have periorbital edema and a puffy face on the hypofunction side versus exophthalmos on the hyperfunction side. We have a normal or small thyroid gland in the hypofunction and an enlarged thyroid in the hyperfunction. Heart failure occurs in both, but the causes are different. Bradycardia is the reason why heart failure occurs in hypofunction. Tachycardia is the reason why hyperfunction has the heart failure. We have constipation in hypofunction, where we have weight loss and diarrhea in hyperfunction, cold intolerance in hypofunction, warm skin and sweaty palms in hyperfunction. We have edema in the extremities on hypofunction and pretibial edema in the hyperfunction. In conclusion, love your thyroid.